Okay, we're going to get started. Welcome to Grand Rounds. Today, Dr. Quinnece M, one of our chief residents, is going to talk to us about trauma in pregnancy. So we'll give her our full attention.
Good afternoon. My name is Dr. Hurdle. This is my grand. Oh, sorry. Hi, Dr. Hemorrhage. Is that better? Okay. So this is my grand rounds on trauma and pregnancy, and I have nothing to disclose. Okay, so the precise incidence of trauma in pregnancy is unknown, but is estimated to complicate approximately 1 in 12 pregnancies. It's the leading non-obstetrical cause of maternal death. It also has fetal implications, such as spontaneous abortions, PPROM, preterm birth, uterine rupture, placental abruption, and stillbirth. Unintentional trauma accounts for a large portion of major trauma during pregnancy, with motor vehicle crashes being the most common. So if you look at this slide here, this is kind of a ballpark figure of the most common types of trauma in pregnancy. The most common being motor vehicle crashes, the second being domestic violence, and the third, falls and slips. So we're going to talk about motor vehicle crashes first. The incident is estimated at about 200 cases per 100,000 pregnancies, 0.61 pregnancy admissions per 1,000 live births. It's one of the leading causes of maternal and fetal mortality, accounting for approximately 1.4 and 3.7 per 100,000 maternal and fetal deaths, respectively. It's the major risk factor for adverse outcome is improper seatbelt use. Impact with the steering wheel can be avoided with proper use, and improper use of the seatbelt has been associated with fetal damage. So you want to discuss proper use with your patients. If you look at this figure here at the bottom, the lady in the pink shirt is not wearing her seatbelt properly. The lat portion is crossing her abdomen, and the lady in the green shirt is wearing hers properly. The shoulder strap should traverse the clavicle and then go in between the breast, and then the lat belt should go underneath the abdomen, crossing the anterior superior iliac spines and the pubic symphysis. Airbag deployment does not appear to be associated with an increased risk for maternal or fetal injury, and the National Highway Traffic Safety Administration recommends that the breastbone should at least be 10 inches away from the dashboard or steering wheel, and that the seat should be moved back as the pregnant abdomen grows. Excuse me. And of course, you want to remind patients that airbags are designed to work with seat belts, not in place of them. The use of intoxicants is a major risk factor for motor vehicle crashes during pregnancy. In one study, 43.5% of patients at a major trauma center following an MVC tested positive for some type of intoxicant. In another study, alcohol was implicated in 45%. The major concern with motor vehicle crashes in pregnancy is the strain placed on the uterus, which could lead to placental abruption, which the incidence in pregnancy with trauma is 6%. Here in the lower right-hand quadrant, you can see an ultrasound of a placental abruption. That's actually a complete abruption with the placenta being up top. Right here, this is the uterus, and that's all blood. So if you see this, the fetus is probably already passed away, and you should probably start thinking about replacing blood and the possibility of DIC. So with placental abruption, the mechanism involves the difference between the tissue properties of the uterus and the placenta. The uterus being elastic and the placenta being inelastic. It's caused by shearing forces at the placental uterine interface. Also, amniotic fluid is non-compressible, and trauma involving the abdomen can lead to amniotic fluid displacement and uterine distension. Even in non-severely injured pregnant women, they are still at risk for placental abruption. With motor vehicle crashes, the risk of preterm birth and perinatal death afterwards seems to increase only if delivery occurs immediately afterwards. And the incidence will be 0.4% less than 20 weeks, 3.5% afterwards. And it likely reflects the severity of trauma. So We're going to talk about intentional trauma. This increases the risk of preterm birth by 2.5-fold and low birth weight by 5-fold. The most common form is domestic violence, unfortunately. And this may include physical injury, sexual assault, isolation, stalking, psychological abuse, reproductive coercion, and it's aimed at establishing control. It's most prevalent among reproductive aged women. Some risk factors include maternal or partner substance abuse, low maternal education level, low socioeconomic status, unintended pregnancy, history of domestic violence prior to pregnancy, unmarried status, and history of witness violence as a child. Potential lifelong consequences of domestic violence include emotional trauma, physical impairment, chronic health problems, and death. The U.S. Department of Health and Human Services recommends domestic violence screening and counseling be a part of a woman's preventative health visits. For prompt assessment, you should assess the patient immediately if you see any signs of depression, substance abuse, request for repeat pregnancy tests for no desire for pregnancy, recurrent STDs. During pregnancy, you should screen at the first prenatal visit, each trimester, and then postpartum. High rates of birth control sabotage and pregnancy coercion are correlated with unintended pregnancies, and the severity of violence may escalate during pregnancy and during the postpartum period. Special populations within the pregnant population include adolescents, immigrants, and our pregnant patients that we sometimes see with disabilities. Okay, so domestic violence during pregnancy is associated with increased rates of spontaneous abortion, admission to the NICU, preterm birth, poor weight gain, infection, anemia, stillbirth, pelvic fracture, placental abruption, and also direct fetal injury. Retrospective and prospective studies have associated domestic violence with peripartum depression. So it's very important to screen your patients. This picture here is kind of hard to see, but it's an MRI of a trauma-related fetal epidural hematoma. So the arrow is pointing to the location in the baby's brain where there was suture disruption and hemorrhage resulting from domestic violence. Studies have shown that self-administered or computerized screenings are as effective as doctor interviews in regards to disclosure, comfort, and time spent. So how do you do it? You want to make sure the patient is alone and in a private area. You want to avoid terms such as abuse, rape, battered. Use a non-judgmental strategy. If you need an interpreter, make sure it's someone professional and not a family member or a friend. You want to include a framing statement that we screen all patients. It's not because we suspect that you're being abused. Inform them of the confidentiality of the conversation and what the law mandates regarding disclosure. Some sample questions include, has your partner ever threatened you or made you feel afraid? Has your partner ever tampered with your birth control? Has your partner prevented you from using a wheelchair, respirator, or other assistive device? And you want to keep printed resources available in private areas, the examination room, restroom, and make sure your staff are trained. If you ascertain that the patient is involved in a violent relationship, the first thing you want to do is assess the immediate safety of her and the rest of her children. Reporting abuse of children is mandatory, but it's controversial in regards to domestic violence. So you want to refer to your state laws. In the state of Louisiana, it's not mandatory. Documentation is crucial. It may be used for evidence in any future legal proceedings, so you want to include an accurate reflection of the patient's condition. Take photographs, quotations. You want to try not to force the patient to keep information in their purse or secretly place it in their shoe or something. It may lead to aggression if found by the person who is abusing her. And you want to try to refer them to a local domestic violence agency and offer them a private office phone instead of their cell phone to use. And then you want to also discuss the best form of future communication with them before they leave. So here's just a list of resources here if you want to memorize maybe like a hotline and a website. that would be helpful. At the bottom, these are resources for the healthcare provider. There are some patient education cards, which were created by ACOG and the National Domestic Violence Hotline, some assessment tools, and then a summary of state laws can be found at the bottom website. We'll move on to slips and falls. So the mechanism of action of the increased risk of slips and falls in pregnancy is that the increased joint laxity of weight gain, increased joint laxity and weight gain during pregnancy can affect gait, predisposing to slips and falls. 1 in 4 pregnant women will fall at least once while pregnant. The majority occur indoors. 40% involve falling from stairs. In a study involving pregnancy outcomes after hospitalization for falls by Schiff, he discussed a population-based study where 80% of hospitalized women who fell were in their 3rd trimester, and the most common injury was fracture of the lower extremity. He also compared the study group to a pregnant control group that did not have any falls, and there was an increased risk of preterm labor, placental abruption, and fetal distress in the group that fell. So you want to counsel patients about this as well. Penetrating trauma. Most evidence in pregnancy, or most of resources, come from 2 retrospective studies. 9% of all pregnant trauma admissions are due to penetrating trauma, the most common being handgun. It's associated with an increased fetal mortality as high as 73%. And in this study or in a study by Awad et al., where he performed selective laparotomies on pregnant trauma patients, during a 16-year period where it was during the Civil War in Lebanon, the fetal mortality was 50% and then 14% for the moms. Okay. Suicide and homicide. Suicide, the incidence of suicide in pregnancy is about 2 per 100,000 live births, 3 per 100,000 live births for homicide. Suicide accounts for 20% of postpartum maternal deaths. That's a lot. So if you think the patient's depressed or something, you might want to work it up. Pregnancy may be protective for women at high risk for suicide and homicide. There was a study performed on the vital statistics records in North Carolina. It was a retrospective analysis from 2004 to 2006 by Samarenda et al., which compared pregnant patients to non-pregnant ones, and the suicide rate was about 30% lower in pregnant patients, 50% lower in postpartum patients compared to non-pregnant controls, and the homicide rate 73% lower in pregnant patients and 50% lower in the postpartum period. Substance abuse is the best identifier for detecting women at risk for suicide, and unfortunately, a lot of our patients have problems with substance abuse. Another major risk factor would be fetal death. Suicide and homicide is often associated with domestic violence. It may be a contributing factor in up to 50% of cases of suicide. Unsuccessful suicide is also associated with adverse pregnancy outcomes. There's an increased risk of preterm labor, cesarean delivery, need for transfusion, respiratory distress syndrome, and low birth weight. Maternal death occurs in 2% of cases after suicide attempt with ingestion of medication. Burns. Information during pregnancy is limited to case report and series. They suggest that the impact of burns depends on the total body surface area affected. As the total body surface area affected exceeds 40%, mortality rate for the mother and fetus approach 100%, with sepsis being a major risk factor. Reports from major burn referral centers state that maternal and fetal mortality are significantly increased with smoke inhalation. After severe burns, maternal age and trimester do not appear to affect maternal and fetal outcome, and pregnancy itself does not appear to independently alter maternal survival. Electrocution. Reports during pregnancy are sparse. Among 15 cases of severe electrocution, fetal mortality was about 70%. There was a prospective study of 31 pregnant patients who sustained minor injury from household appliances. There was no differences in mode of delivery, birth weight, gestational age at delivery when compared to controls. Poison during pregnancy. Literature is mainly related to suicide attempts. Accidental poisoning is not as widely reported, but there are some case reports that describe medication overdoses in the hospital setting. So how do we manage trauma in pregnancy? Primary goal is going to be to stabilize the mom. Fetal outcomes are directly correlated with early and aggressive maternal resuscitation. Joint evaluation by trauma and OB should occur when possible, and it should be simultaneous, not sequential. Both maternal and fetal morbidity and mortality are reduced when the multidisciplinary treatment team is mobilized to provide care. A primary survey should follow the non-pregnant guidelines, include trauma history, vital signs, and an assessment of the patient. You want to remember to displace the uterus to one side. It's very important. Here are some things that should alert you to a probable catastrophic trauma and the need to perform ACLS if the patient is in cardiac arrest, obviously. If she doesn't have an airway, blood pressure of less than 80/40, heart rate less than 50 or greater than 140, respiratory rate less than 10 or greater than 24 breaths per minute, and then a fetal heart rate which is out of the norm. You want to look at the mom. Once you see her, quickly inspect the abdomen. Does she have a seat belt strap injury? Is she contracting? Is she tender when you touch her? Does she have bruises? Of course, you want to get an IV going, probably at least 2. Order some labs. You want to consider UA, UDS, and serum alcohol as well. You should also assess her cervical spine. And you may need skilled personnel or personnel skilled with difficult intubations due to difficulty in intubating patients that are pregnant. There's an increased risk of aspiration. There may be some edema of the soft tissue. If there's a C-spine injury, you're definitely going to need somebody who does this all the time. And then you may need to use fiber optic bronchoscopy. If there's severe hemorrhage, you want to transfuse FFP, platelets, and packed red blood cells at a ratio of 1:1:1. Volume resuscitation can be complicated by the gravid uterus due to aortic cable compression. So of course you want to laterally displace the uterus, possibly tilt, although that's not ideal in some cases. Do that once the patient is beyond 24 weeks. It can increase cardiac output up to 30%. If the fetus is viable, as soon as you can, you want to make sure you start continuous maternal and fetal monitoring. So I wanted to quickly talk about some things that could cloud the picture in a pregnant patient who's a trauma victim, just because we may know this stuff, but other people in the emergency room, whatnot, may not. But so in regards to the normal physiology of pregnancy, generally the heart rate is going to increase, blood pressure decreases. There's physiologic and iron deficiency anemia in pregnancy. So there's a lot of different things to consider. There's an increase in blood volume. There's a lot of things to consider when it comes to looking at a pregnant trauma patient. One of them is being that not until you have moderate blood loss of at least 25–35% of blood volume will you see an appreciable resting tachycardia. So the usual signs of hemorrhage are not going to be present until you lose quite a bit of blood. And then once you really start seeing the patient become hypotensive and tachycardic, that really means that you're behind. So this is an algorithm for how to manage trauma in pregnancy. This looks kind of complicated, but we'll just go through it really quickly. So once you assess the patient here, you basically want to see, is she responsive? Does she have an airway? What are her vital signs? If she's stable, she's talking to you, she looks fine, then you're going to go down this part of the algorithm. So basically, if she doesn't have any kind of injury greater than some bruising, some contusions, you can just assess the fetus. Probably don't really need to get any imaging done, and just counsel the patient on some things to look out for in regards to trauma in pregnancy, such as placental eruption. But if the patient is unstable, she's not responsive, her vitals are not normal, then you want to go ahead and start your ACLS protocol. Remember to displace your uterus to one side, make sure the patient is on oxygen. The trauma team should already be there, NICU should be there, get your IVs in, draw blood, and then if the fetus is viable and the patient is semi-stable, you may want to get some heart tones. Okay, so what if you have to do CPR? So the pregnant uterus and placenta serve as a major shunt, and it makes CPR a lot less effective. So as you can see here, you have this baby in the uterus and it's pressing on the vessels here, the aorta, the IVC, and so if you're trying to do CPR, it's not going to be too effective. So you want to use the lateral tilt, or the lateral tilt is typically recommended. May compromise your CPR compression forces, so what you actually want to do is just manually displace the uterus. If you can, if for some reason you don't have enough people there, then you can place a padding underneath the patient's right buttock. All right, so when would you consider doing a C-section? Perimortem C-section in the trauma patient. So perimortem C-section is basically defined as a C-section that's performed in the face of maternal cardiac arrest. It can be life-saving. It may aid in maternal resuscitation and perfusion. However, no evidence exists that cesarean delivery in this setting actually improves maternal survival rates for any specific condition. Outcomes, as far as the C-section being helpful, is dependent on a lot of different factors. The interval between cardiac arrest and delivery, the cause of the arrest, where the arrest takes place, expertise of the team. Chance of maternal survival after cardiac arrest, even with vigorous resuscitation efforts, is reduced compared to a non-pregnant patient. Properly performed CPR provides only a maximum of 30% of normal cardiac output, and you have to remember that cardiac output is increased during pregnancy. C-section may be appropriate when there's imminent maternal death. After 4 minutes to properly perform CPR that has failed to revive the patient. This standard can rarely be met in actual practice or even in ideal situations. The literature says that it should be performed through a midline abdominal incision from the xiphoid to the pubis, through a midline vertical uterine incision through the upper segment of the uterus. Fetal outcomes in regards to intact survival is best accomplished within 5 minutes of maternal arrest, so you essentially have 1 minute to get the baby out. Fetal survival is unlikely if more than 15 to 20 minutes have passed since the loss of maternal vital signs. This is just the bottom portion of the algorithm. Once the patient is stable, you want to go ahead and assess the fetus a little bit more, maybe get some labs, and then depending on the type of trauma, that's going to lead you or guide you into what you should do next. Talk about burns and what you should do as far as managing them. Your priority should be aggressive fluid resuscitation, respiratory support, and wound care. The ultimate goal is to transfer the patient to a tertiary care facility. Some authors advocate for delivery in the 2nd and 3rd trimester if the mother has sustained burns that accounts for more than 50% of the total body surface area. Direct inhalation injury can result in significant airway compromise, and you want to consider carbon monoxide poisoning in this setting. In regards to penetrating injuries, if you need to place a chest tube, you want to place it 1 or 2 intercostal spaces above the usual landmark to avoid abdominal insertion because everything's pushed up by the uterus. Maternal outcomes are more favorable with penetrating injuries than with blunt trauma because the uterus protects the non-reproductive viscera such as the bowel and the spleen. But of course, the baby is going to be more susceptible to trauma with penetrating injury. Visceral injuries are less likely when the injury site is anterior and below the uterine fundus. Fetal death is dependent on the amount of placental or umbilical cord disruption and has been reported as high as 70% with gunshot wounds and 40% with stabbings. So management of penetrating injuries is going to depend on the entrance, location, and gestational age. Gunshot wound to the abdomen, these patients typically undergo XLAP with debridement of damaged tissue. Stab wounds, you're going to manage them like a non-pregnant patient. During the XLAP, surgical team should never let the uterus prevent them from adequately exploring the abdomen. It's not an automatic indication for hysterotomy and delivery of the fetus. If the fetus is dead, vaginal delivery is still not an inappropriate option unless there's obvious uterine injury or you're considering placental abruption, just simply because it's going to be very difficult to manage the patient in the post-op period if she's abrupting. Fetal heart rate monitoring should be performed during the surgery if the fetus is viable. Be prepared to form a C-section if necessary, possibly a C-HIS if bleeding cannot be controlled after delivery of the fetus. After the X-flap, unless the patient requires ICU management, she should be taken care of on the labor unit. If the pregnancy is still intact, it's not uncommon to experience uterine contractions of preterm labor once anesthesia has worn off. If the patient is going into preterm labor and you're not suspecting an abruption or bleeding from any other source or a compromised fetus, then you can use tocolytics, but you want to try and avoid breathing, as it may mask undiagnosed hemorrhage. And remember tetanus prophylaxis if it's indicated. Peritoneal lavage can be performed during pregnancy. It's usually used if you're not really sure if the patient is bleeding intraperitoneally. Rebound tenderness and garden may be less apparent with advanced gestation. Diagnostic lavage can be performed safely in all trimesters using an open direct visualization technique or by ultrasound guidance. And you want to put your incision supraumbilically. Pregnancy-specific criteria for positive lavage has not been reported, so you want to use non-pregnant parameters. If the patient has a pelvic fracture, gross or microscopic hematuria is usually suggestive of a pelvic fracture due to bladder or urethral injuries. Retroperitoneal hemorrhage is a very common complication of pelvic fractures during pregnancy. If the patient does have a pelvic fracture, that doesn't necessarily preclude vaginal delivery. Most can safely attempt vaginal birth afterwards, even in the 3rd trimester, as long as the fracture is not severe, dislocated, or unstable, or the patient doesn't have a large healing callus that would preclude delivery. Imaging during pregnancy should be undertaken if it's clinically indicated. Ultrasound and MRI are not associated with known adverse fetal effects. According to the American College of Radiologists, there is no single diagnostic procedure that provides a radiation dose significant enough to threaten the well-being of a developing embryo or fetus, especially in mid to late pregnancy. Exposure of less than 5 rads has not been associated with an increase in fetal anomalies or pregnancy loss. So if there's a concern about the patient needing a medically indicated x-ray, you should get the x-ray, essentially. But if an ultrasound or MRI would suffice, then you should consider that instead. If the patient is going to need multiple x-rays, you may need to consult with an expert's endosimetry calculation to see how much radiation the fetus is actually being exposed to. Radio-opaque and paramagnetic contrast agents are unlikely to cause harm, but should only be used if benefits outweigh risk. So we'll talk about ultrasound a little bit. Fast scan, which is done in the ER, focus assessment with sonography for trauma. It's safe. It detects intraperitoneal fluid. It looks at the subxiphoid, the upper quadrants, and the suprapubic area. There's a retrospective cohort of approximately 2,300 ultrasounds that were performed, and essentially it says that FAST is reliable during pregnancy. In regards to diagnosing placental abruption, ultrasound is unreliable, so if you don't see anything suggestive of abruption on ultrasound, it doesn't mean that the patient isn't abrupting. When a clot is visualized, though, the predictive value for an abruption is very high, and the fetus, like we discussed before, is probably already passed away. Abdominal helical CT, very helpful in evaluating multiple organ systems. There's abdominal trauma during pregnancy, but of course it's going to be more radiation exposure with the CT. It's up to 3.5 rads per study. But once again, doses less than 5 rads are not associated with increased risk of anomalies, pregnancy loss, or growth restriction. So you just want to weigh your risk versus benefits. Once the patient is stable, you want to do a thorough examination, look for old bruises, perform a speculum exam, especially if there is bleeding or hematuria. Even if you suspect a pelvic fracture, you want to look for ruptured membranes, vaginal lacerations, check their cervix, do an ultrasound, check the viability of the fetus, presentation. If you don't know how far along she is, you can do a growth scan at that time, and then place the patient on the monitor. So Tachycardia, bradycardia, sinusoidal patterns, these are all suggestive of fetal compromise. ACOG recommends a minimum of 2 to 6 hours continuous maternal fetal monitoring after trauma. You can consider discontinuing the monitoring after 4 hours if there's less than 1 contraction every 10 minutes. The fetal heart rate tracing is reassuring and the mother doesn't have any pain or bleeding. And why 4 hours? Well, that's because placental eruption has not been reported when there's less than 1 contraction present in any 10-minute interval in any 4-hour period. So we're going to quickly discuss fetal maternal hemorrhage. Traditionally, it's been reported to occur up to from 9 to 30% during trauma. More likely to occur with anterior placental location. Severity of injury and gestational age do not reliably predict fetal maternal hemorrhage. And there's little evidence that the Clyde-Becky test predicts adverse immediate fetal or neonatal outcomes. When the gestational age is less than 20 weeks, 1 gram of RhoGAM should suffice because the expected fetal blood volume is not likely to exceed that covered with 1 dose of RhoGAM. But just as an aside, if the patient is over 20 weeks and you're trying to get RhoGAM from the blood bank, they may want a RhoGAM evaluation because of this, because the patient is over 20 weeks and they can't really say if 1 vial is enough. We'll review the University Health protocol again. So when we do a RhoGAM evaluation, we don't use the Clyde-Becky test here, which is why I'm going over this. They look at a maternal blood type and they do an antibody screen. Then they essentially perform the indirect Coombs test. If it's positive, the mother gets 2 vials of RhoGAM. And they also perform something called a fetal maternal erythrocyte distribution screen. This is a reference test, which is essentially the Clyde-Becky. So we can send off for it if we need it. And if the screen is negative, the mother still gets 1 vial of RhoGAM. Some medical legal implications after trauma. Clinicians are likely to have to offer a medical opinion on the outcome of pregnancy, especially if there was maternal and fetal mortality or significant morbidity. Your findings should always be carefully documented. Your records will likely be revisited, and it's important for you to document everywhere, in the labor unit, in the OR, in the ER. And now we're going to go through a couple cases. You want to do this one, Mari?
Yeah.
The ED calls the labor unit. I'll read it. You can answer the question. The emergency room calls the labor unit. There is a 17-year-old G3, P0020 at 29 weeks and 1 day by a 25-week ultrasound. She has a history of PCP use. She's en route via EMS after a gunshot wound to the chest. It was on the right side. She was reportedly shot by the father of the baby. She'll be in the trauma bay in 3 minutes. Your staff is on the toilet with severe GI distress and is unavailable. How would you initially assess this patient?
All right, so she's coming in the ER. Well, first we're going to get a set of vitals on her. Sure. Oh, we're going to check her ABC. Yeah. So yeah, once she comes to the ER, I would guess, hopefully I'd already be down there, but the ER docs would be assessing her, probably the ABCs, because anyway, so check for airway, breathing, circulation, get a set of vitals. I would think if it's a gunshot wound to the chest, well, they're going to be up top, and we're going to be more assessing her baby, getting heart tones and all that.
That was it.
Well,
Okay, so here are her vitals. Her respiratory rate is 32, blood pressure is 70/30, heart rate is 130. What should be initiated?
so we want to get all our labs and everything. We want to get IV access. With a gunshot wound to the chest. I don't know how that would work. But what do we have on the baby? Do we have access?
Nothing on the baby yet.
I don't know what's next.
ACLS.
Well, her heart rate's, well, yeah, her blood pressure is low. But her heart rate's not, wasn't over 140 that you said, but the rest of it. All right. So yeah, we do that. What does that entail? Because I don't know.
So you do your ABCs. You might want to, if she's unresponsive, then you have to do the protocol for.
So that's just chest compression.
And she's in So it's like a ton of different protocols.
All right.
But another thing here is she's tachypnic, so you want to get anesthesia more because she's probably going to need to be intubated. So she got a chest X-ray. It shows she has pneumothorax and the patient needs a chest tube. Where do you advise the resident to place it?
Okay, you usually go, I don't know where you go. You said go high.
Yes. 1 or 2 spaces above the usual landmark.
Where is it?
Fifth is the usual one.
Fifth? Okay. So we're going to go third.
Okay, who wants to?
Right above the rib.
Oh, we still got some more questions. You ready? What factors in this case place the patient at risk for domestic violence?
Young.
Gunshot. She's pregnant. She's young. She uses drugs. She's unmarried. What are some things that this patient is at risk for in regards to domestic violence?
Preterm labor. Low birth.
And what about her? Yep. Suicide, depression, and death. And of course, those things about the baby. Should you consider that maybe her previous pregnancy losses were not really spontaneous?
Oh, yeah.
Yes, that is true. Because trauma can lead to pregnancy losses, and there is often pregnancy coercion, which may lead to elective abortions in some cases. Okay, second case is the last one. Miller, you want to do it? Sure. There's a 27-year-old G3 P2002 at 37.3 by 12-week ultrasound presented to the labor unit after a fall. She reports she tripped on a rug at home wearing high heels. She landed on her abdomen. She has a little bit of pain. She's stable and she's in no acute stress. The patient reports she cannot stay very long as she's had a long day and is tired. She wants to go home as the ultrasound is good. Is the NST necessary?
Yes.
Good. ACOG recommends a minimum of 2 to 6 hours of continuous maternal fetal monitoring after trauma. How long is long enough?
4 hours.
Yep. 4 hours if contractions are less frequent than 1 every 10 minutes, the heart rate is reassuring, and there is no maternal abdominal pain or bleeding. Patient's blood type is A negative. Should Rogaine be administered?
If she has her
Yes. And then the last question, the patient insists on wearing high heels daily and reports that she was born in heels. How should she be counseled on falls and pregnancy?
she needs to try to fall on her back.
There is an increased growth weight gain during pregnancy, which can predispose to fall, and she should consider short heels or maybe some flats. Okay, so some key points. These are in no particular order, but one of the major determinants of surgical outcomes after trauma during pregnancy is the severity of injury. Domestic abuse and motor vehicle collisions are the most common mechanisms. Substance abuse is commonly a factor, so you want to educate and counsel and screen your patients. Pregnancy should not lead to underdiagnosis or undertreatment of trauma due to fears of adverse fetal effects. You want to remember to place your uterus to one side when you're trying to resuscitate the mom. If the baby is viable, you want to put the patient on continuous maternal fetal monitoring as soon as possible. The patient should be evaluated jointly by trauma and OB. The NI should also be there if the baby is viable. Personnel trained in difficult intubation should be readily available. Pelvic fractures don't necessarily preclude vaginal delivery. Burns in the 2nd and 3rd trimester, you want to consider delivery if the total affected body surface area is more than 50%. FAST is reliable in pregnancy, and Perimortem C-section may be appropriate if there's imminent maternal death or after 4 minutes of unsuccessful CPR. So that is it. Any questions?
Question, more of a comment. Well done. One of the things about pregnant women in high heels, though, that I've found with patients, not only is their laxity in joints and change in weight, but they lose their peripheral vision. And so they constantly fall over steps because they're not seeing below their belt. And so you do need to warn them. Their peripheral vision is off and they don't notice it because it's a gradual change in most people. Sometimes it's more sudden, but gradual change where they're actually not seeing their feet when they're walking. So advising them to not necessarily stop wearing high heels, but pay attention to where you're walking, looking down when you walk, things like had a couple of patients who had to come in and get monitored, and they were mad, and everybody was fine, but they felt like a clot. They didn't seem to love it.
We had a patient who fractured her ankle. She had to get surgery on it.